All righty, GI. We've reached GI. GI is by far the best chapter in my opinion. Um, it just makes sense. It really, like, the system makes sense, the anatomy makes sense, the pathologies are very easy and interesting. Let's start off with GI embryology. First and foremost, what you need to know is that in the 6th week of development, what happens is that you have a physical herniation of the midgut through the umbilical ring, okay? And at the 10th week of development, it will return into the abdominal cavity, and it rotates around the SMA when it returns into the abdominal cavity on week 10. And so there's going to be a lot of associated pathologies here, so that's why I'm bringing it up right now. That's pretty much the only thing that I would say for normal GI embryology. The midgut, 6th week is when it leaves through the umbilical ring, and 10th week is when it returns, rotating around the SMA. All right? Now let's talk about the ventral wall defects. So this is a defect in essentially that 10th week of development where you don't have the gut coming back into the body, okay? So first, we have gastroccesis versus omphalocele. Gastroccesis is going to be a para-umbilical herniation. So it's not through the actual herniation, is not through the umbilicus. It's going to be next to the umbilicus through the abdominal wall defect, through one type of defect in the abdominal wall. What you need to know is gastroccesis is not covered by peritoneum or perineum, I should say, or amnion, okay? It's just out there. It's not associated with chromosomal abnormalities, and it's a relatively good prognosis. They just patch it back up, okay? What you will see is that you'll see an increase in AFP when the baby is in utero, because this is an open, or just like an open neural tube defect, this is like an open GI defect, open ventral wall defect. Gastroccesis, you will see an increase in AFP. Okay, next, omphalocele. Omphalocele is the herniation through the umbilicus, okay? So it's an umbilical herniation, and what you need to know is that it's a failure for the gut to return into the abdominal cavity, right? As we said on the 10th week of development, same thing. We have the failure of the gut to return into the abdominal cavity. So this is going to be covered by peritoneum and amnion. Peritoneum and amnion. Now, what you need to know is that it's associated with congenital anomalies like trisomy 13 and 18. Beckwith-Wiedemann syndrome is also another high association for omphalocele, all right? So trisomy 13, 18, and Beckwith-Wiedemann is associated with omphalocele. Omphalocele is covered by peritoneum and amnion, and it's through the umbilicus. Okay, it's not covered by skin, though, because a congenital umbilical hernia is failure of the umbilical ring to close, but it is going to be covered by skin, okay? And this is associated with Down syndrome and congenital hypothyroidism. Okay, so remember, that's going to be covered by skin. Most of the time, they will close spontaneously, but if it's a big defect, it could be associated with, once again, Down syndrome and congenital hypothyroidism. The key difference between omphalocele and congenital umbilical hernia is that congenital umbilical hernia is covered by the skin. Omphalocele is not covered by the skin, and you have a herniation of the abdominal contents through the umbilicus. All right, very easy for the ventral wall defects. Remember, going back to the embryology portion, 6th week is when it leaves. The 10th week is when it comes back in. So they could show you a photo on ultrasonography, and you might be able to see the GI contents outside of the baby's body. I feel like I remember this question. Maybe not, but I don't know. I feel like I remember seeing this question. But essentially, you see the GI contents outside of the baby's body, but you have to pay attention to the week, because if it's within that week span from the 6th week to the 10th week, then it's normal physiology. Now, if it's after the 10th week and it's still outside the body, then you know that it could be potentially like a gastroccesis or an omphalocele. All right? Remember, gastroccesis increase in AFP because it's an open wall defect, okay? Open wall GI defect. Next is a tracheoesophageal anomalies. So there's multiple things that can occur. You could have esophageal atresia. There could be esophageal atresia with a distal tracheoesophageal fistula. And there could be, a pure tracheoesophageal fistula or a pure esophageal atresia. Okay. Now, overall, what I want you to know is that esophageal atresia with distal tracheoesophageal fistula is the most common. So that means that you have essentially a blind ending pouch of an esophagus, and then there's the trachea that connects to the other distal portion of the esophagus. So there's no one clear pipe right down. Okay, so that's the most common cause. And the patient's going to present often in utero with polyhydramnios, right? Because the patient can't swallow the amniotic fluid, which helps clear the amniotic fluid. So you're going to have an increased amount of amniotic fluid, polyhydramnios in utero, when a patient has an esophageal atresia with distal TEF, okay? Now, another thing that you're going to see is that on presentation, right when the baby's born, on their first feed, they have excessive drooling, they have coughing with their first feed, they're choking, vomiting with their first feed. That is all a very high yield key sign for tracheoesophageal anomalies. Very key, okay? Now, the clinical test, which is going to be questioned a million times out of a million times. I still get questions on this. The test in order to tell if there is an EA with a distal TEF is that you do an NG tube. You place an NG tube, and if you have a failure to pass the NG tube into the stomach, so you place the NG tube and then you take an x-ray. If the NG tube's tip is not in the stomach and it's just stuck up top, failure to pass that NG tube because there's an esophageal atresia, right? The esophagus just ends in a blind pouch, then you know you have diagnosed tracheoesophageal anomalies, all right? Or an EA with a TEF, okay? So remember that excessive drooling and coughing on the first feed. Next is our intestinal atresias. So we have duodenal atresia and jejunal and ileal atresias, okay? Now, this is going to present with bilious vomiting. So it's bilious vomiting, all right, and abdominal distension within the first couple days of life, okay? Because the baby can't pass any food. Think, your duodenum wasn't fully formed, or your jejunum wasn't fully formed, or your ileum wasn't fully formed. It can't get passed. You literally cannot get food. You could take it down the esophagus, it could go to the stomach, but then right when it reaches the duodenum, it's stuck there, okay? And the reason it's bilious vomiting or bilious vomiting is because usually the abnormality or like kind of the endpoint of the atresia is after the location in which the bile enters, which is at the sphincter of Oddi, right? So just keep that in mind, all right? So that's why it's going to be bilious vomiting. If you have an obstruction before, which we'll talk about that in a second, then you will have non-bilious vomiting, okay? So now we're in intestinal atresias. You will have bilious vomiting within the first 1 to 2 days of life. Now there's two types, duodenal atresia versus jejunal atresia. Duodenal atresia, it's failure to recanalize. Recanalization means essentially like you don't, the extra cells. So what happens first in the formation of our GI tract is that you form just like one solid tube, okay? It doesn't become hollow. And then later on, as you grow, it starts to hollow out, and that's called recanalization. Okay, so it forms originally as a solid tube, and then it starts to recanalize or hollow out. So it's a failure to hollow is duodenal atresia, okay? And what you will see is that you will have a double bubble sign on x-ray, very high yield. Take a look at it, what it looks like. Okay, you'll have a dilated stomach and proximal duodenum are both dilated, all right? And it's highly associated with Down syndrome. So here are your key takeaways. Duodenal atresia, you'll see double bubble associated with Down syndrome, and it's due to failure to recanalize. Boom. Next is jejunal and ileal atresia. For jejunal and ileal atresia, this is due to some type of vascular occlusion or vasoconstrictive issue that led to jejunal or ileal atresia. So that's very, very important to know, okay? It's not due to failure to recanalize, it's due to some type of vasoconstrictive issue. And that mainly could be the mom like smoking tobacco, because that's vasoconstriction, the mom doing cocaine during pregnancy, that's also a vasoconstrictive drug, right? So that could lead to jejunal and ileal atresia, so that's highly associated. And it's usually disruption of the SMA. Okay, so the SMA is usually the vascular issue. So it's like an ischemic necrosis that usually is causing the jejunal or ileal atresia of the SMA mainly involved. The SMA is usually involved, okay? So keep in mind, you're going to see a triple bubble on jejunal or ileal atresias on x-ray, and it'll be like an apple peel atresia is what it's called. You can take a look at what that looks like. So for jejunal and ileal atresia, keep in mind vascular issue, a vascular pathology affecting SMA mainly. And it could be vasoconstrictive drugs of cocaine or smoking during pregnancy. You're going to see triple bubble and apple peel atresia. All right. Next is hypertrophic pyloric stenosis. Very easy, very straight up. But what did I tell you? The first thing I told you is that if you have an obstruction before the sphincter of Oddi, that means you're going to have non-bilious vomiting. Well, guess what? If you have hypertrophic pyloric stenosis, the pylorus is the obstruction. So that's before you even get to the duodenum. That means that's before you even get to the sphincter of Oddi. So you're going to have non-bilious projectile vomiting. Okay, non-bilious projectile vomiting, but it occurs a little later. It's going to be at around 2 to 6 weeks old because it's smooth muscle. So that smooth muscle originally isn't going to be as strong. And then as you grow up, as you grow older, like 2 to 6 weeks old, that smooth muscle becomes hypertrophied, it becomes stronger, and then it can lead to the symptoms of non-bilious projectile vomiting, okay? What they will always say is that, well, not always, but what they can say is that there's a palpable olive-shaped mass, okay, on examination. They're going to have, once again, the non-bilious projectile vomiting at around 2 to 6 weeks old, so a little later onset. And it's highly associated with firstborn males and exposure to macrolides, okay, the antibiotic. All right, so keep that in mind, firstborn males and exposure to macrolides. Now, this non-bilious projectile vomiting can result in hypokalemic, hypochloremic metabolic alkalosis, because essentially you're vomiting out all of your stomach acid, which contains HCl, right? And HCl, obviously, it's going to lead to a decrease in chloride in your system, so it's going to be hypochloremic. And you're also vomiting potassium out too, so it's going to be hypokalemic as well. All right, so we have a hypokalemic, hypochloremic metabolic alkalosis. So decreased potassium, decreased chloride, secondary to our non-bilious projectile vomiting, which can lead to a metabolic alkalotic state. Okay, very, very straightforward. On ultrasound, you're going to see a thickened and like lengthened pylorus, right? Obviously. And for treatment, you're going to probably want to do a surgical like resection of the pyloric muscles, a pylorotomy, pyloromyotomy. Weird name. Honestly, that's not even high yield. I don't know why I said it, but that's that. Now, last thing for our embryology is the pancreas and the spleen embryology. What they want you to know first is the pancreas is derived from the foregut, and we're going to talk about foregut, midgut, hindgut in the anatomy section, but the pancreas is a part of the foregut. Once again, we're going to hit that a little later. And there's something known as annular pancreas, okay? This is lower yield, but essentially you have abnormal rotation of the pancreatic bud, and it forms a ring of pancreatic tissue around the duodenum. So it causes an obstruction around the second part of the duodenum because of the abnormal rotation of the pancreas, okay? And it can cause that duodenal narrowing, which can lead to obstruction and vomiting, and it's associated with Down syndrome, okay? Now, this can present later on in life, which is weird, but honestly, what I would know about annular pancreas is that it's abnormal rotation of the pancreas, which leads to pancreatic tissue compressing the second part of the duodenum, causing duodenal narrowing. Much lower yield compared to the rest of the things I discussed, but still important just for clarity on all the pathology issues. That's all for embryology. Next is going to be discussing anatomy.